Clinical story: skeletal muscle iron channelopathy. A 24-year-old gentleman presented to the neuromuscular clinic with a history of recurrent episodes of muscle weakness since adolescence. He reported that the weakness occurred intermittently, often after strenuous exercise, prolonged rest following exercise, or after consuming large carbohydrate-rich meals. During these episodes, he experienced difficulty rising from a chair, climbing stairs, and occasionally lifting his arms above his head. Interestingly, between attacks, he remained completely normal and was able to perform all daily activities without difficulty. Further questioning revealed that, apart from episodic weakness, he occasionally experienced muscle stiffness, especially during exposure to cold weather. He described difficulty releasing his grip after a firm handshake and noted that repeated movements gradually improved the stiffness. There was a significant family history, with his father and paternal uncle having experienced similar symptoms, suggesting an inherited neuromuscular disorder with autosomal dominant transmission. On examination during an asymptomatic period, higher mental functions and cranial nerve examination were normal. Muscle bulk and power were largely preserved, and deep tendon reflexes were intact. However, percussion of the thenar muscles elicited delayed relaxation, suggestive of myotonia. Sensory examination was normal, indicating that the pathology was likely intrinsic to the muscle rather than involving peripheral nerves. The episodic nature of weakness with normal strength between attacks raised the suspicion of a skeletal muscle channelopathy. Skeletal muscles depend on specialized membrane proteins known as ion channels to regulate the movement of sodium, potassium, calcium, and chloride ions across the sarcolemma. These channels are essential for generating muscle action potentials and initiating muscle contraction. Abnormalities in these channels can disrupt muscle membrane excitability, leading to periodic paralysis or myotonic syndromes. Genetic testing was therefore undertaken. Molecular analysis demonstrated a mutation in the SCN4A gene, which encodes the alpha subunit of the skeletal muscle voltage-gated sodium channel. Sodium channels are composed of 4 homologous domains, D1-D4, each containing 6 transmembrane segments, S1-S6. The highly charged S4 segment acts as the voltage sensor. Mutations affecting this channel are responsible for disorders such as hyperkalemic periodic paralysis, paramyotonia congenita, potassium-aggravated myotonia, and hypokalemic periodic paralysis type 2. The patient's history of cold-induced stiffness and paradoxical worsening with repeated activity suggested paramyotonia congenita, a classic sodium channel disorder. Serum potassium estimation during attacks occasionally demonstrated elevated potassium levels, supporting the diagnosis. During evaluation, the patient's younger sister was also assessed because she complained of episodic weakness precipitated by heavy meals and rest after exercise. Her attacks were associated with low serum potassium levels. Genetic analysis revealed a mutation in the CACNA1 gene encoding the alpha-1 subunit of the skeletal muscle L-type calcium channel. These calcium channels are composed of 5 subunits, alpha-1, alpha-2, beta, gamma, and delta, with the alpha-1 subunit forming the ion-conducting pore and determining channel characteristics. The alpha-1 subunit contains 4 domains, D1-D4, each comprising 6 transmembrane segments, and the S4 segment functions as the voltage sensor. Mutations in this channel are the most common cause of hypokalemic periodic paralysis type 1. As part of family screening, another relative reported a history of generalized muscle stiffness since childhood, particularly after periods of rest. The stiffness improved with repeated movements, a phenomenon known as the warm-up phenomenon. Genetic studies demonstrated mutations in the CLCN1 gene encoding the skeletal muscle chloride channel. Chloride channels stabilize the resting membrane potential and prevent excessive muscle excitability. Mutations in this channel lead to myotonia congenita, inherited either as the autosomal dominant Thomson disease or the autosomal recessive Becker disease. A further family member had developed progressive proximal and axial weakness in middle age. Muscle biopsy revealed central cause within muscle fibers, and genetic testing identified an RYR1 mutation. The ryanodine receptor, located in the sarcoplasmic reticulum, is essential for releasing calcium into the cytoplasm during excitation-contraction coupling. The receptor consists of four identical subunits arranged as a large tetramer. Mutations in the RYR1 gene are associated with central core disease, malignant hypothermia susceptibility, and late-onset axial myopathy, including bent spine syndrome. The family was specifically counseled regarding the risk of malignant hypothermia during general anesthesia. Another affected relative presented with episodic weakness accompanied by palpitations and a history of syncopal episodes. Physical examination revealed low set ears and mild clinodactyly. Electrocardiography demonstrated ventricular ectopy with prolonged QT interval. Genetic analysis identified a mutation in the KCNJ2 gene encoding a potassium channel, establishing the diagnosis of Anderson-Tawil syndrome. This syndrome is characterized by the classic triad of episodic muscle weakness, cardiac arrhythmias, and dysmorphic skeletal features. Thus, this family illustrated the broad clinical spectrum of skeletal muscle ion channelopathies. Despite differing presentations, all these disorders arise from mutations affecting ion channels that regulate skeletal muscle excitability. Recognition of episodic weakness, myotonia, family history, serum potassium abnormalities during attacks, and characteristic clinical features is crucial in guiding targeted genetic testing and establishing an accurate diagnosis.